their first job or whatever, this idea that you're there too as a family member is really important. And this idea that they're just going to flourish on their own and don't talk to them for 3 months or 4 months, I think is rubbish. Our next speaker and the last speaker, first of all, thank you for your fortitude. Everybody is still here. This is terrific. Our last speaker of the night is Dr. Ode Hennon, who, despite physical impairments and others, is able to come. Ode is an extraordinarily busy clinician. She's the co-director of our cognitive behavioral therapy program, associate professor at Harvard, and really has done some of the most innovative work in working. I have to say, she works with some of the toughest kids, these highly mood dysregulated adolescents. You think you're having a bad hair day, she has 7 of them in a row. So, but we really appreciate your talking today a little bit about mood and anxiety disorders in this age group. So thank you so much, Ode.
Thank you.
Thank
you. It's my pleasure to be here. And although I'm clearly unable to walk, I hopefully can instruct you a little bit around mood and anxiety disorders in young adults or emerging adults. We call them all different things. Emerging adults I really don't like. It sort of seems like
So now you can see what it's like to be the chief of a science. We can't even agree on a title.
It's not just you though. It's the field as a whole. So it's not just an MGH. But anyway, so I have one very, very small. I'm not sure the $35 a year I make on Oxford. That's 6 people who bought my book. Thank you. But anyway, that's my disclosure. So I have a funny feeling because I came a little later. Because actually, I was at my clinical practice in Wellesley today. So I have a funny feeling this may be a little repetitive. So I apologize. Although repetition is the key, right? So you will clearly have understood the needs of young adults by the end of this. So here's what we know. So this is actually one of the highest age groups for risk for onset but also continuation of mental health concerns. So that some studies find that nearly 1 out of 2 kids have or have had a significant mental health concern by the time they reach college age. And in particular, I'm going to talk about mood disorders and anxiety disorders because those are some of the disorders that we see most frequently, and also college and beginning of college are high-risk times for onset of these disorders. So here's a graph that shows, this is actually now a well-known study, and I just want to highlight that when we're talking about mood and anxiety disorders, we're actually talking about a constellation of different disorders that might have different treatment needs. So although I'm lumping them together, highlighting the differences between different anxiety disorders and mood disorders is really important, not just in understanding the diagnosis, but also in developing an accurate and helpful treatment plan. But having said that, if you look at the rate of prevalence of anxiety disorders and mood disorders, 30% of young people 18 to 29 had or have an anxiety disorder, 20% have any kind of mood disorder, about 15% of those have depression. So again, very, very common conditions. This is always a scary slide, but the presence of these disorders is potentially lethal. So what we know is that among young adults, suicide is one of the leading causes of death. And so you see that at 15, for both males and females, suicide leads the way in cause of death. And then we see that sort of decreasing steadily until we're wise and not quite as much at risk. So accidents and suicides happen more frequently than we'd like to think, and are preventable. So intervening, as you've now heard, early intervening effectively is really key to help these young individuals not just survive but thrive as well.
Social media is to factor in that suicide.
Well, so that's an interesting point, and actually I'm working on my next talk on social media. So I think social media can be a source of great stress and distress. I also think, though, that it behooves us to leverage social media to help the kids that we work with. So that's something I'm going to talk about because I think look, it's here to stay. We're not going to get rid of it. And so we have to figure out how can we use that to inform kids about disorders and about treatment options. How can we use it to increase social support? But yes, there are concerns because I think, like anything, it can have some pretty detrimental effects for vulnerable kids. Sorry. So, and again, I promise I won't just leave you all with scary, scary slides, but but I think it's really important because we kind of tend to poo-poo this, and there's almost sort of a banality, like everyone's like, oh, I've been depressed too. So I think in some ways the increased recognition of mental health concerns has been fantastic, but it's almost, I think, sometimes led to a kind of banalization of it. Like everyone's like, oh yeah, I'm totally anxious. I'm totally, well, no. We're talking about kids who are deeply suffering and with great need. And so we know that the onset and the presence of these disorders during this age group can lead to a number of very poor outcomes. And so again, I always feel as though when I'm working with this population, we're really at a juncture where we can help shape the trajectory. Again, I don't mean to, you're all gonna walk out with anxiety. but it's, look, it's a reality. You're here because you're concerned. So the question is, what do we do to help sort of shape the trajectory of functioning? And I think there is a lot that we can do. You've already heard quite a bit from other people. All right, I'm not gonna go to the point. All right, so what can we do? Let's jump right into that because I think that's gonna be the most helpful thing. Well, so I'm going to mention medication. I'm a cognitive behavioral therapist, so I'm going to predominantly focus on the psychological treatment aspects, but it is important to know that there are a number of excellent pharmacologic interventions, and the data tell us that for individuals who have moderate to severe symptoms of anxiety or depression, the combination of an evidence-based psychosocial treatment like CBT and medication really is the most efficacious and the most helpful. And I think sometimes we wait too long to treat, and every year that the child suffers is a year of suffering that we could have potentially prevented. So I'm not somebody who treats with medication, but it is really important. And when we're talking about a disorder like bipolar disorder, which also is a mood disorder, medication is really key and very reluctant. So I did a study many years ago of young adults with bipolar disorder and got flooded with demand. I had just come back from maternity leave and put an ad on the T, and within a month had 80 calls and was completely overwhelmed. And in fact, people were very interested because it wasn't a psychopharm study, it was a therapy study, and kids were desperate for care and very much needed care. But only 57% of these young people were on medications. So very, very impaired, very ill, suffering tremendously, probably the rawest group I've ever worked with, and yet incredibly reluctant. So that's, I think, another target for us with these populations I'll talk about is really how do we help them access treatment in a way that is helpful, feels good, and helps prevent some of these outcomes.
How many months does it take to find the right meds or combination of meds?
Well, yes. So it is tricky. And for, again, as you've heard, for this age group, this sort of trial and error, but there's actually a lot of data. I mean, look, you don't always hit it out of the park right away. An accurate diagnosis is key, right? So, for example, the problem with bipolar disorder is that the predominant mood state is depression. And so a crackerjack evaluation that will help tease out whether this is unipolar depression or bipolar depression is essential. Because often, without that, you might have the wrong treatment. But I don't think that it has to be sort of endless months and years. Sometimes it is, and that is hard, and we really work with kids to tolerate that. But not treat.
6 months, 3 to 6 months is normal.
Yes.
Bipolar.
Yes, but also don't forget that the average amount of time that then a child or an individual suffers undiagnosed, untreated between onset and treatment is 10 years. So I'm willing to muck around for 3 to 6 months to catch it early and save a whole decade of suffering. It's an imperfect science, and there's a lot more work that we need to do and that we're trying to do. But and again, like a lot of what I'm talking, this is actually, I know this conversation, right? I have it all the time because these are fair concerns, and I'm not poo-pooing it. But on the other hand, particularly with mood disorders, I was just saying this because it's a very, very bad time of year for a lot of people. We never stop and we don't give up. We keep working to find the right treatment, because saying someone like, oh, you're kind of better but not really better, that's not an option. Like, we have to really keep working and do everything we can. And when someone is suffering, there is no such thing as like okay-ish. We really have to keep finding the right, and sometimes it is frustrating. And I know, kids feel like they're, experiments that we keep changing, and particularly with mood disorders, that's often the case, right? But I fully believe we can get there, and we're going to have them have a good life, and not treating and not helping it's just not an option. But I understand the frustration and the concern on part of the patient and the child. So I want to talk a little bit about cognitive behavioral therapy, or CBT for short. So it's a talk therapy, but I do have a couch in one of my offices, but no one lies on it and tells me their dreams. I wouldn't even know what to do with it if they, good for you. My dreams are not very boring. I dream about phone calls I need to make, or whatever. So it is a therapy that focuses on measurable goals. It's a collaborative enterprise. So the idea is that I know about tools and skills that can help. You and your family know about your needs, your difficulties, what works for you and doesn't. Together, we're going to come up with ways to implement these tools and strategies to work for you. I'm going to give you a menu of options. Some of them you'll be like, oh, I'm out. I don't want this. Others will work, and we'll really figure out how to individualize treatment for you. Sessions are structured, the therapist is active. Again, it's a very sort of collaborative enterprise, and the idea is that people need to practice skills not just in the room, but between sessions, right? Behavior change, cognitive change, these are hard. So if you come once a week and talk with me for an hour, and then you go back and don't practice it between sessions, treatment's not going to be that effective. So there's a lot of focus on active practice of these tools in real life as much as possible, as much as is realistic. So here's the general model, just because I think it helps to understand. I'm sorry, it looks a little hard to read, I apologize. I think it's helpful to understand these aren't just sort of tools that we're willy-nilly picking from the air. We're really conceptualizing the individual's needs systematically and then drawing from our knowledge of what tools can address each of those needs. So here's the idea. For a symptom, let's say anxiety, there's a triggering situation or an event. Someone with social anxiety gets invited to a party. And they experience the symptom of anxiety, and I don't know how to make someone not anxious, right? And as parents, I will even fuss after this one, we've all said, a kid will say like, oh, I'm really scared, and we all say, oh, don't worry, don't be anxious. Least helpful thing. It's so automatic, right? Yeah, I don't know how to do that. I wish it were a light switch that we could sort of flip on and off easily, but we can't. But what we can do is break the symptom down into component parts and address each of those component parts in turn. So something like anxiety, depression, anger, has an emotional component, an affective reaction, a physiologic component, so how your body responds in that situation, and a cognitive component. What thoughts do you get in that situation? Together, that then leads to a behavior. People do something. So someone go back to my social anxiety example, you get invited to a party, your emotional reaction is anxiety, your heart starts to pound, you get butterflies in your stomach, you feel sort of shaky, and you think, I can't do this, no one will talk to me. Your behavior in that situation might be that you say, oh, I'm really busy, I can't go. And the consequence of that is that you're alone in your room. Maybe the next time the person doesn't invite you to hang out, you kind of feel down on yourself. Yeah. It's important to note that in addition to focusing on the individual, we do consider the individual's predisposition. So we just had a fantastic talk on neuropsych, and the role of assessing and intervening around that. So what's the child's temperament? What's their learning style? What's their genetic makeup? What's their learning history? What prior experiences do they have that may have contributed to the symptom? What's the family environment? And what's the broader environment, social, cultural, community, in which the symptom gets expressed? Because we want to consider each of these in developing a treatment plan. And as I mentioned, by using this model, we can use different tools to target each of these components. So for the antecedent, the triggering situation, we can help people recognize, anticipate, and modify, right? So sometimes you get a lot more bang for your buck working on the front end than waiting till we're downstream at the consequence and intervening there. Even for parents, right? You're parents, so you've got a kid who melts down every single time they go into Target, which is designed to make kids melt down. I'm so bitter every time I go, because you've got networks of psychologists whose only job it is to make your child want to buy. So you can work on consequences and punish the kid, when they melt down, and come up with behavior plans, et cetera, which I do. Or you can figure out that maybe Target needs to be a solo, parent-only run and try to limit the number of times that your kid gets tempted, right? There's merit in both. But again, I think, and so having said what we have said about adolescents and young adults and their difficulties with planning ahead, with putting, you know, the pieces together without repeated experiences, that's a big part that we try to help them do. So what happened the last time? Let's think through what's likely to happen again, because being prepared really helps. It can take time. For the physiologic response, we teach relaxation, mindfulness, breathing, exercise, sleep. So there are really a number of different tools that we want to access to try to decrease someone's physiologic reactivity. For depression, where the person feels sort of heavy and there's a real sort of weight to it, we might, again, in addition to mindfulness, which has really nice data for depression, try to activate them by engaging in physical activity. So for adults, exercise is now a first-line intervention for depression, and for some people is actually quite important. Again, very hard to do when you're depressed, but again, I think we need to really focus on some of these other aspects in addition to sort of medication therapy. For thoughts, we do cognitive restructuring, which I'll talk a little bit more about. For the emotional reaction, we do something called exposure, which I'll also talk a little bit more about. And we try to really promote alternate coping responses and reinforce those coping responses for individuals. So affective education, and I always say this, and it always seems like kind of like, really, you're spending time, but I'm always struck by how often people struggle to accurately identify their emotions in the situation and to link up, again, the situation with the emotion and to differentiate emotions. Like I feel crappy about. And to identify low-level emotions. So I think whether it's because some low-level emotions are hard to recognize or people sort of white-knuckle it until things are unbearable, I do think that often, as I said, but we wait too long to intervene. So much easier to work on something that's a 4 out of 10 as opposed to a 10 out of 10. So helping to identify low levels and then coming up with a plan when those happen is helpful. I mentioned techniques to reduce physiologic arousal. I mean, sometimes this is one thing that some young people will sort of poo-poo, like, I don't want to breathe, I don't want to do yoga, I don't want to, but I think that there's a lot of ways to do it. And so the question is, all mindfulness is, at the core, is active focusing of attention in the moment. You can do that doing anything. You can do that playing basketball. You can do that listening to music. You can do that, you know, dancing with your friends. So you don't have to be in a yoga studio, but what it is being only present in the moment and letting all other thoughts and feelings kind of pass by, being aware of them, but not clinging to them and not pushing them away. And I think that's a phenomenal experience that people should have routinely. So figuring out how can you generate that, because that is a break, especially for someone who's suffering, having even if it's seconds, sometimes we're talking about seconds, of relative peace worth a lot. So I really think it behooves us to sort of find ways to make this more accessible to folks who may have different ways of doing this. Sleep hygiene, that's a funny one. Yeah, I try. It's so important, and it's so hard to get kids to sleep regularly and enough. And I get it, but more and more we see how important it is for mood disorders, for ADHD, for concentration. So figuring out, and I really, if your sleep schedule, because I get it, if your sleep schedule is 2 a.m. to 10 a.m., that's okay. Let's make sure we don't schedule classes at 8 a.m., but let's try to keep, doesn't work so well, but let's keep that regular. Because I think what's hard is when some nights you're only sleeping 2 hours, or you have multiple nights in a row, or every night you're like, I have so much schoolwork that I'm only sleeping 4. That is not a sustainable thing. Also oversleeping. I've got some kids who are sleeping 13 hours a night, and we know that that's unhelpful. So trying to create regularity in their routines, which is so hard in college. I mean, there's really no other age group where every 3 months we completely overhaul their schedules. I mean, it's quite remarkable to me. So some of this is just implicit in how things are structured, but as much as possible, trying to create constancy. And there's nice data that for bipolar disorder and mood disorders, that is a really key intervention. There's something about the routines, and there are some interventions that are so strict, where you get up at the exact same time, you eat breakfast exactly the same time, you get dressed, and something about that it is very powerful. So again, I think it's hard to get kids to do that level of routineness, but these are low-hanging fruit potentially, right? So as much as we can promote these kinds of lifestyle changes, the better off our kids are. Sorry, I'm rambling a little bit. Problem-solving skills. So everyone can problem solve, but the idea here is it's a systematic way. I'm sorry, I don't know how much longer I have. Okay. To evaluate problems. So often you have to define the problem accurately, which is harder than it sounds, because often problems sort of feel mishmashed and confusing. So, I hate school. That's I don't know how to solve that. But let's think about how to phrase that in a way. I am behind on my English assignment, and I have no idea how to structure it. Okay, now we can do something like this. So we work with people to really kind of get specific, to frame the problem in a way that's solvable, generate potential solutions. So as a rule of thumb, ask people to generate at least 3. They don't have to be good. We're not going to evaluate them at that time. Just brainstorm. Because often people sort of jump to a solution and kind of run down that path. We want to take the time to really think about different options and then evaluate them. Come up with a multi-step plan. Implement the plan, evaluate it. So if you think about it, we're really asking people to do a lot of very hard work here. Cognitive restructuring, which is the idea that people's experiences, or responses, to experiences are mediated by thoughts. So in the very same situation, how you think about the situation will change how you feel and what you do. And we know that there are certain thinking patterns that are associated with anxiety and depression, and that we can help people become more aware. They're fleeting. These thoughts are quick, they're rapid, so often we're not really that aware of it, but we can help people become more aware and then generate alternate ways of thinking that are more helpful, more realistic, less anxiety-provoking, or less negative. And this is exposure. So I always say, if you remember nothing about anything I say, and you are concerned about an anxiety disorder, if you want anxiety to get better, this is what needs to happen. And a lot of the other things that we do are sort of a primer for this. So here's the idea. We're built to stay away from things that are scary and dangerous. It's a very adaptive response, right? That's the fight or flight that we talk about. So when you're in a situation that elicits anxiety, you're designed to get out of there, which is great, except when the situation isn't dangerous and is something that you either need to do or want to do. Taking tests, living independently, hanging out with friends, et cetera, et cetera. Powerful response, but we can override that, but it's really hard. We're overriding a fundamental biologic imperative for survival. But here's how we do it. If, when you're in that situation, you don't escape, you don't avoid, over time, your anxiety will decrease. We're designed to habituate. And if you repeat that again and again, you will learn, because it's called sort of extinction learning, not to fear that situation. You will learn that you can cope with the anxiety. You will learn that the feared outcome doesn't happen, and you will build mastery. So this is what we do, and it's a big part of what we do in CBT for anxiety, is we help people gradually. Now, I do it like we start off here. We don't. Okay, a couple things. First of all, I'm not saying that 4 times and you're good. I just have to, it's illustrative purposes only. I really wish it was just like 4 and you're good to go. But and I also do it like we start. I don't usually start at 80 because people just don't come back. So usually what we do is develop a fear hierarchy. Oops, sorry. There we go. And gradually move up the list. Again, my goal is to have people say, oh, that was kind of hard, but I can do it. Not get me out of here. She's completely out of like, done. Sometimes both happen. But so this is really, really key. And if you want an anxiety disorder to get better, this is almost always the key thing. So just very quickly, so I do my time-lapse brain, but you've already seen it. So I'm going to kind of quickly, it's actually a lovely brain. It just really shows the sort of frontal lobe development that happens over time. I just think it's such a beautifully illustrated way to show. And it's also important, they only went to 20, but really, I think we keep sort of pushing the age back. Now we're talking about 20 and 25 to 30. But really, even between 16 and 20, which is part of the age group they're really talking about. There's a lot of change that goes on. I'm going to jump over this. I also want to highlight that so I've talked about all the risks, but there are a lot of sources of resilience in youth that I think we need to tap. So yes.
Just on the brain slide, is there a difference based on gender?
Yes. Okay. I'm going to sound mildly sexist, but I don't mean to because the biology is a little sexist in this. So yes, there are differences. And this is one of my favorite presentations of all time, was by Jay Geed, I would say his name, from NIH, who showed the slides of female and male frontal lobe development. And what you see among girls is around puberty, a rapid increase, and then sort of a gradual kind of, it sort of flattens out a bit. And with boys, it's like, and I'm like, oh my God. And I share this all the time with my middle school and high school girls. I'm like, because this explains everything. This is why the boys are still shoving pencils up their nose at like 8th grade, and the girls are like, so yes, there are, so in the end, yes, but, so it's more in terms of the growth curves that are differences. But I think it's helpful because it actually depathologizes. I'm going to need to wrap up in a second, but I also want to highlight that we really can use some of the strengths of this. I will make fun of young people and millennials a little bit, but I actually think they have remarkable strengths, and I think there's so much that they bring to the table, and so much that they know that we didn't know, that I think we can really value and use in treatment as a positive. And I think it's just, and I think you've heard this before, that when we're working with young people this age, I think we just have to adapt. The treatment modalities are the same, but the question is, how do you help people access that? How do you work within a framework that respects their needs, respects their values, recognizes that they are not going to appreciate an authoritarian approach to treatment, that they have the right to come to things in their own time, in their own way. And we want to repeatedly present, but not sort of coerce or force. And to really try to do things like integrate technology, which I've talked a little bit about, which, for example, this is an age group that I really like to do video sessions with. They're video natives. Given the mobility of this age group, I think we can really do a lot of work remotely. I think for kids who may have financial limitations, coming into treatment can be very hard. And the data suggests that CBT provided via online video sessions is as effective as CBT face-to-face. So I think it kind of allows us to reach a much greater audience. Now, there are limits. We're not allowed to do it across state lines because of licensing rules, but even, for example, out in Western Mass, where there are a number of colleges and there's a dearth of resources, there are a lot of kids who can't drive in 3 hours that we can work with. So I think there's a lot of hope, there's a lot that we can do, and a lot that we can really engage kids around, help them. So thank you. Thanks for listening.
Let me get you a chair.
Yeah.
Is this effective for
Yeah, so there are a number, I didn't present them, and so oppositional defiant disorder is a little interesting with young adults, right?
Did you want some water, by the way?
There's been a number of CBT interventions developed for adolescents who can be aggressive, oppositional, and non-compliant that have good data behind them. And obviously the parents and other adults are involved in that treatment to figure out how to help with those behaviors. And a lot of it is focusing on negative cognitions. So often these kids misinterpret social situations and react unduly aggressively. We will teach them how to relax, how to breathe, how to do things to decrease physiologic arousal, talk about effective communication patterns. So yes, there are a number of interventions that can be helpful.
One is, how do you know if your child is just anxious or if he's having? Second question is, if the child is not willing to seek treatment or go, get therapy for whatever reasons.
Yeah. Those are both phenomenal questions. The first one is a lot. So there were two great. So one question is, how do you know that whether your child is just sort of anxious or has an anxiety disorder? And two, what do you do if the child is unwilling to engage in treatment for whatever reason? So the first question is a lot easier than the second. So we think, so anxiety is a normal experience, and we think of it as being a disorder when it is interfering, when it's causing high levels of distress, or when it's persistent and prolonged. So for example, everyone worries a little bit sometimes, right? So before a test, a lot of people might feel anxious. But we might think about it being a disorder if the child or the young person is worrying for a week before or days before, can't sleep, can't concentrate, is so overwhelmed that their mind's going blank when they're taking the test, is upset and crying either before or after, is trying to not go to school because they can't face it. So those are, again, that's a fairly extreme example, but those are really the things that we're looking for. It's a problem. So it's only a problem if someone says it's a problem. Having said that, I think that there are a lot of interventions that we can use even for lower levels of anxiety. I think we don't have to wait until it's so severe, because a lot of the things that we're talking about are easily taught. And in fact, I'm sort of working right now with the Benson Henry group to try to teach some of this in schools and to develop programs so that we're teaching resilience to all kids and not only waiting until things are so bad that they need professionals. So that's the first question. So the second question is harder. And it's a big part of, so the question is why not, right? So what is it that's interfering with this child's ability to get and receive help?
Probably stigma.
Yeah. So the question is then, is there something that we can do to help reduce that stigma? Can we have them engage with peers who have similar difficulties so they can feel less alone? Are there online resources they can see? Are there ways to have them access care that feels private? Can we engage them? So the nice thing about, so for example, with CBT is that it's time limited. So I might say, look, and it's a course. Like it doesn't feel like you're being shrinkified. Like you're learning. But you're learning tools. You're learning skills, and so you can come in. I'll say, come meet me for 5 sessions or 3 sessions. See how it feels. If you hate it, if you think this is useless, if it's humiliating, it's okay, fine. And I'll keep that door open because sometimes people come back. I don't believe in forcing someone into therapy and sort of, because then that's going to be how they think of it. And then maybe when they're in a different place, they'll be less willing to seek it because it's such a negative reaction. I don't know if that's what I'm saying.
No, that's great. I just want to say that any questions, by the way, also for Dr. Kaneko or Dr. Forcello would be great. Yes? Oh, sorry about that.
Oh,
We have
sorry.
ding, ding, ding. No, go ahead. No, go ahead. That's great.
Oh, so the list of medications, why is one medication prescribed for depression and anxiety at work? Good question. And sometimes it addresses one issue and not the other.
Well, they have, I can comment. So the medications we use, there's different medicines that we use. It turns out that there's a lot of overlap outcome for certain medicines. So the serotonin reuptake inhibitors and the serotonin norepinephrine reuptake inhibitors are typically now thought to help both the depression and anxiety, including at higher doses OCD, for example. That class of medicines is what we rely on. But when you also have medicines that work predominantly for depression, like lamotrigine would be one of them, Lamictal. We also have ones that work predominantly for anxiety, like buspirone or benzodiazepines. So often where there's anxiety, there's often some mood, and when there's mood, there's often anxiety. So it's it's not totally symmetrical. And for those, we often are we're picking up symptoms of the other. And so you'll try to target and say, we'll work on both disorders simultaneously.
And lower levels of serotonin or other things in the brain
Yeah.
present differently within persons.
That's right. Low serotonin is thought to be more connected to mood disorders and suicidality than it is to anxiety, quite honestly. So, yeah.
Having sort of had difficulty. Are there any good
repeat it.
Yeah, no, that's a good question, because it is a fair comment that CBT sometimes is hard to come by, and there are often long waiting lists. Although we keep expanding, so our waiting list is at least temporarily shorter. But so, and I don't know the age of your daughter, but there are a number of books that are excellent for both anxiety and depression that are kind of a little bit of a self-help. There are some excellent websites as well, like ADAA, the Anxiety and Depression Association of America, is a really great resource. Quality data-based recommendations. They have online support groups. They also have places where you can try to look for therapists. There are fairly recently there's been a move towards what we call iCBT, which is computer-based, kind of self-administered CBT. That's still being tested, but the data so far seem actually quite promising. So it's been used with OCD, for example, or anxiety disorders. So I think that's going to be yet another way. There are even some apps now that offer elements of this. So I do think that there are a lot of ways, maybe even if it's not quite the full model, to access useful tools.
We had somebody over here. Yes.
I have my list, and my daughter has a college fair on Wednesday. So I know you're not a college advisor.
No.
You have a list of 75 schools that are
Great. Awesome.
New England schools that are not too big, that have professors that teach the courses, that are willing to talk to parents, that have good services.
Sounds perfect. So what's the question?
What's that list?
Oh, geez.
Okay.
I don't mean I'm not asking you to be an advisor in that way, but schools that have a reputation for helping.
That's a loaded question.
Mental health issues.
I don't have a good answer for that, just because I think each one is individualized to what the needs actually are. Like, is it a learning disability, or is it more of like an executive ADHD? Is it both? So I think having really good so it's a college fair you're going to? Okay, so maybe, I'm trying to think of good ways. I would go on their websites and see what they list. Usually colleges that are more accessible and are more approachable about disability resource, or giving services for disabilities, will have a link listed on their website, will have like really good descriptions on what they provide, because they clearly see that as an emphasis and that's what they want to highlight in their program. So that might be something to do before. When you're, it's a really hard question. It's hard. But I typically would, I would do your research beforehand, and see if there's anything in like U.S. News on like populations of students that have learning disabilities that attend these colleges, like see what populations tend to go there. I'm trying to think of other things I can give you. I know oh, are you going to comment on that, or a different question?
I'd just like to comment, just being a parent, have gone through this, so. And it
Yeah.
for you, like who does? You're here, you're doing everything you need. Ask the questions.
I also think if you're sitting there going, I'm just stuck on that a little bit, or there's too much, these educational consultants
Great.
are really awesome, because they'll sit down and they'll really narrow it to a few schools, and they know the subtleties between the schools, and it really does help. So I've learned that seems to be a really good way. It is money well spent, quite frankly. It's that I think it's you're going to make a much better informed decision moving into it. And the 6 colleges or 8 colleges that you actually visit, you'll feel much more comfortable are all sort of appropriate. So you're not way out in left field on that decision.
And obviously having your kid involved in that conversation is important too, right? Like, because you should start having conversations about like, what do you feel best supported in? Is it a smaller classroom? Is it a bigger classroom? Do you think you'll need extra supports in X, Y, and Z? And that starts that self-advocacy dialogue about what learning supports they're going to need in college, and helps them make a more informed decision when they do have to decide between those 5 colleges that seem perfect for them. So thinking about those things too is dialogue for that kind of advocacy piece too.
Our school our high school has a college night where a bunch of colleges come, and you can go from who would talk to them, that was really helpful.
Yeah.
So if your high school doesn't have one, call some of the surrounding ones and see what it
That's a
is.
good idea.
Well, that's a
Usually in
That's a
everybody hear that? That's terrific. And the only other thing I would add is that don't forget the community colleges also, and there are some community colleges like Middlesex, Massasoit, a few other ones that really lean in a little bit for the kind of kids that we treat and are often great stepping stones then to go on to a four-year education. So it's a win-win. It's everything you were talking about, but they have extra services available, et cetera, and it's local. We're fortunate that way. Yeah.
Yeah, I have a question just about communication. So my child actually went away to college, undiagnosed with depression, began to self-medicate with alcohol, had to go on medical leave, returned here, actually came to the ARMS program, and then in getting the substance abuse disorder treated, the mental health piece reared itself. Recommended to get additional treatment. So he has since returned to college. The substance abuse piece he's got a handle on, but the mental health piece is still very much a work in progress. And so, he's away, and my wife and I sort of want to check in on his well-being, but also want to foster that sense of independence. And I'm sort of wondering if you or perhaps anyone here has any advice in terms of communicating with him about how he's doing without
Yeah, I just, and I think the check-ins that I talked in at the end, where you can actually lay eyes on your child at least once a week, you just say, this is just what we're gonna do, right? To kind of make sure and have check-ins, and so like thinking about just being able to see, even if they're saying they're fine, do they look fine? Do they look disheveled? Do they kind of look spacey? Like they haven't slept a lot. So just kind of looking at them, I think more than just a phone conversation can be really helpful. So Skype or video chat, FaceTime. But as far as getting you access to kind of like how they're doing at school, though, that can be a little bit more dicey. And so calling the Disability Resource Center about what they might be able to kind of, if he gives you permission, what you're able to have access to and who you can talk to and be a part of his like advocacy team too. I don't know if anyone else has thoughts.
No,
on that.
I lean in. I ask parents to lean in a lot when you have a kid who's depressed and especially college reentry.
Yeah.
So I think, we always worry so much about concussion and when are you ready to go back into the game and when are you ready to go back to school. Nobody talks about reentry to college after you've had a flame out for whatever reason. And I am not in a hurry to get kids back into college right away, right back into that four-year college or whatever that's a distance away. I'm much more inclined to treat it like a medical. And I'd say that if somebody took a baseball bat and whacked your knee, you're not running stairs in 2 weeks. It's going to be a slow recovery. And I want you home and I want to watch and I want to be part of that treatment, get you back into community college, take some courses and build you back up to see that you're ready to go back to school. But I think that sudden launch back to school is not in anybody's best interest. Plus, it's very expensive to go back. And then if you have another problem, it creates yet further problems. So in terms of that leaning in, there has to be contact. And I think I try to negotiate that during my session. If they're here, is it okay if I am concerned? So I'm going to be the bad guy here. What is reasonable? What do we agree on? And if you're doing it on your own, I always say do it when you're talking about when you're going to recharge their debit accounts. So we'll give you that. But how about weekly I recharge and weekly we talk? And I recharge it when we talk. It's a really good, positive.
Yeah, that's good.
And it seems to help a little bit to facilitate the phone call.
And I think your question is an important one, and particularly with mood disorders that we know can often recur. What we try to do is create a plan, particularly when the person's well, talking about how would you know that you're not doing well? What are the early warning signs? Who is part of your support team? So this idea that someone's going to go and figure this out all by themselves is a no. What do you want your parents to do or not do? How can they be supportive? What would they, if you needed to go to the hospital, where do you want to go? Because I think in the moment is not the time that you want to be starting these conversations. And so it's really sort of preemptively. And having then the young person be part of the planning. And then knowing as a parent, okay, even though they're saying, no, I'm fine, I'm good, I just missed that class because I was tired, and then I missed that class because I was, so those are, what peers do you want to involve? So I think it's really that's gonna be essential. And
That's
as a
great.
treater, I always communicate with parents. I'm not holding, like, absolutely not. I'm not gonna go share, every detail about their little experiences with weed or whatever, but like, if somebody is really struggling, we are all there to support and buffer them, and that it has to be a team effort.
Yeah, how about a couple more questions? Yes, sir.
Real quick on your medicine list, you didn't have Depakote, Wellbutrin.
Yeah, no, Wellbutrin would be one that it was an incomplete list because there are, there's 60, there's what over 120 FDA approved agents for psychotropics, but those are all very valid, very reasonable medications to be used.
The side effects, though, are just so horrific between the hair loss and the weight gain. But my son really hated Depakote.
Yeah, and when you're using medicines, I think you have to be very thoughtful and work with people on trying to minimize that. Pick the newest generation with the least amount of metabolic side effects, and et cetera. And then when you hit certain meds, there are certain meds that the only thing that's working is a med that's going to put weight on or something. And it's really working with the family and the individual to mitigate that. We're also throwing extra meds on. So we use metformin. We use a lot of extra meds that are diabetic meds prophylactically to help keep kids metabolically more stable. And anything you can do. I know it's hard. Parents always want kids to get more exercise and eat well, but it's really pushing that on that front as well as what we're doing medically. I'm not satisfied I am a psychopharmacologist, to just put people on meds and see them gain weight and not do anything. So I'm throwing everything I've got at it and shifting meds and doing that all the time. It's not acceptable anymore to say you're going to gain 60 pounds, maybe 10 or 15 pounds, but much more than that. It's a real, we got to shift. You got to do something different. Yeah.
And lithium, can you be on it for years, or is there a point that?
Yeah, you can be on lithium. Lithium is a medicine used for bipolar disorder, but it's also used for mood dysregulation, and they use it for a lot of excess hyperkinesis or a lot of extra movement in certain disorders, et cetera. And we use it for augmentation therapy for people with major depressive disorder who have not responded to single or multiple therapies. Yeah, you can be on lithium for a long time. What I would say is lithium is a double-edged sword. It's highly effective, yet it can be really toxic to the kidneys. And you have to monitor it really carefully. This is not a medicine to be used lightly. You have to be careful about it. What I like to do is what I call mini-dose lithium. So I like to use another class of agents that I think are safer, and then to reduce the burden and improve, I think it was, who was talking about it, wellness, said, and Yosh, he had to leave, but it's treat early and treat well, get people well. That's why we do our combination therapies. We share so many patients because we want to do that. And lithium does that. It can convert somebody from doing okay to well. But I use what's called mini dose. I use a lower dose lithium and I rely on a higher dose other medicine because everybody if your kids are on lithium or something, watch it carefully. Everybody in our practice, all of our senior psychopharmacologists have had problematic outcomes because of lithium. Saved lives, but we've also damaged kidneys and stuff. So we're really careful about monitoring that and trying to use lower doses, et cetera. When I say we, I don't mean that we did it intentionally or anything, but it was just the chronic effects of that medicine.
How often should they be checking?
Every 6 months or so. And if you're on lower dose and the levels are low, you can get away with yearly checks, for people who are on low dose lithium. But if you're on higher dose lithium, you need to be monitoring it. That's not for people who are not adherent or who are taking and not taking or doubling their dose. You have to be really careful about that. There are certain meds you can get away with that aren't so specific or not so caring about adherence. That one's not one of them that I would do that with.
Doesn't lithium have a problem after a certain number of years? It's not effective anymore?
No, it's highly effective for many years. It's one of the few medicines that shows that it reduces suicidality over time in a whole host of different disorders, et cetera. Any other? Well, I think the time is late. I really want to thank the panelists and the faculty who've been here, and I want to thank you, and I want to thank Judith for helping